Dr. Rafage. This will be January 21st, 2025. We're going to this issue of JAVMA, and this is from March 15, 2017. We are doing a what is your diagnosis right there. And this comes out of the Veterinary College in Dublin, Ireland. So this is they're showing here initially up top, and we'll show you the next one, a bigger zooming in of this, but this is pre and post contrast computed tomography or CT scan of the abdomen and thorax in an 8-year-old, 100-pound spayed female Labrador retriever. The dog had a large, slowly expanding subcutaneous mass in the left cranioventral aspect of the abdominal wall. Regarding the history, this mass was detected initially 11 months prior. They did abdominal radiographs at that time, which revealed a large ovoid homogeneous mass of fat opacity superimposed on the cranioventral aspect of the abdomen. Ultrasound of the mass revealed well-defined homogeneous, mildly echogenic mass that was consistent with adipose tissue and suspected to be located within the abdominal cavity. This mass was about 15 centimeters in diameter. They did cytology, which found clusters of adipocytes with abundant, poorly staining cytoplasm and peripherally located round to oval nuclei, suppurative stromal tissue, and numerous long winding capillaries with elongate nuclei and occasional entrapped erythrocytes. No inflammatory cells, no microorganisms, and no malignancy was found. Blood work showed increases in alkaline phosphatase, alanine aminotransferase, lipase and amylase, cholesterol, and then urinalysis found 3+ protein, 1+ epithelial cells, white blood cells, CAS. The urine protein to creatinine ratio was high. The urine culture was negative. No abnormalities found on ACTH stimulation, low-dose dexamethasone suppression, and thyroid function testing. So those are all the appropriate testing you should perform for a dog that's slightly older, 8 years old, is up there in age for a lab. Let's go over some of these results real quick before we go forward. The blood work showing increases alkaline phosphatase. There's only a few sources of ALK-Phos, ALKP, or ALP in dogs. It's either a stress cortisol response, it could be from the liver, it could be from bone as well. And those are the primary reasons to have an elevated alkaline phosphatase. Then the alanine aminotransferase, that's from liver usually, but also could be from muscle, might be from uterus too, I'm not sure. And then lipase and amylase, those are considered predominantly pancreatic enzymes. However, you can see elevated lipase and amylase with renal disease because I believe they get filtered through the kidneys. Obviously, this dog didn't have any evidence of azotemia. However, he had an evidence of 3+ protein in the urine. That being said, they mentioned the urinalysis here is a free cache, which means it's not sterilely acquired like with cystocentesis. So it's possible that the 3+ protein is from the epithelial cells, leukocytes that were found in the urine from the free cache, meaning contamination from the environment or from the urinary tract and not actual disease. So theoretically, they should have repeated that urinalysis by performing a cystocentesis of the urine, or I would have just done a cysto from the get-go because it's better to do it that way. And then same thing with the CAS. You can find CAS normally in some dogs, but normally CAS also show are concerned for renal disease. But anyway, that's what all that means. So when you think about why this dog has increases in 2 liver values, you have to think of all the sources of those enzymes and think, okay, well maybe either this dog had a hepatopathy of whatever reason that's now getting better, or maybe it's got liver disease now because of whatever this mass is. And so those are things to think about there. And then the lipase and amylase, same thing. Are those elevated because there's underlying renal insufficiency? Are those elevated because the pancreas is involved with this mass? Or is there a separate pancreatic issue that just there's no clinical signs associated with it? Okay, imaging findings and interpretation. Here's your CT scan. Boom. And there's description in case you want to pause the video and look at that description there so you can learn how to read CT. They found a large ovoid, well-circumscribed, fat-attenuating, -110 Hounsfield units, extraperitoneal mass Mass contains a number of well-defined linear, thin, and uniform soft tissue attenuating, about 30 Hounsfield units. Septa of variable orientation and length. There's a dorsal medial displacement of the left 7th to 12th ribs. There's left medial and left lateral liver lobes that were displaced, as well as the head of the spleen was displaced. The intestinal loops and gastric fundus also displaced because of the mass, and there was no contrast enhancement. Treatment and outcome. They performed a midline celiotomy. They removed the mass, placed a closed suction drain in between the left transversus abdominis and obliquus internus abdominis muscles. They checked with the dog 5 months post-op after surgery, and there were no complications, no tumor recurrence. They did not submit the mass because of financial constraints. Now, right off the bat, this is really JAVMA, you guys. So, if you're the clinician and you're thinking you're going to submit this case for a what's your diagnosis, and the owners can't afford to submit the mass for a histopath, and that it would make this case a lot stronger if you had biopsy results, then submit it at no charge. Just pay for it. It's an educational moment here. And then JAVMA for publishing a what's your diagnosis of a tumor with no histopath. That's so weird. It's just bad. Bad call on their part, and bad call on the clinicians who did the surgery, because I would have been like, without a biopsy, I can't approve this paper. So that's really weird. Anyway, comments. Intramuscular lipoma associated with the muscles of the abdominal wall have not been reported previously. It has been reported in thoracic and pelvic limbs. In contrast, infiltrative lipomas are characteristically hypoattenuating, similar to usual subcutaneous fat, but are often associated with fine linear striations in adjacent muscle, indicating infiltration. They also failed to add here with infiltrative lipomas, in contrast to liposarcomas, where liposarcomas will actually bypass tissue planes and even invade bones. In humans, well-differentiated liposarcomas have a relatively characteristic appearance consisting predominantly of adipose, over 75%, and non-adipose, which are septa, nodules, and globular area components. The presence of soft tissue attenuation at 30 Hounsfield units. Septa within the mass has been described in both benign and malignant lipomatous lesions in humans and intramuscular lipomas in dogs. It represents fibrous tissue of the intramuscular space. Although the presence of thin septa is not specific to lipomas or well-differentiated liposarcomas in humans, the latter rarely demonstrates thin septa, less than 10%. On the contrary, the presence of thick septa is a significant predictor of malignancy. Differentiation between intramuscular, invasive, or intramuscular and simple subcutaneous lipomas can only be made on the basis of imaging on CT or MRI, surgery, and histologic examination. Stupid paper, man. Radiographically, intramuscular, infiltrative, and simple lipomas all appear as fat, dense mass. Ultrasound, although the three lesion types can vary considerably in echogenicity, the presence of hyperechoic capsules, hyperechoic stripes or striations, and sharp borders are common features among all of them, making differentiation challenging. In a previous study on removal of benign intramuscular lipomas, recurrence was not reported following removal, with median follow-ups of 12 to 17 months. So this is overall a bad paper. They should have had the biopsy results at minimum, and then they should have gone more into depth about liposarcomas, because even though those are uncommon, they are the most aggressive of the three types of fatty tumors, and they and because they didn't submit it for biopsy, you can't rule out liposarcoma. I would agree that on the advanced imaging, there's no evidence of malignancy, and those tumors are very aggressive and prone to metastatic disease long term. So chances are this probably was a infiltrative or intramuscular lipoma. But the other thing they didn't mention also here is staining of the biopsy. So down below is a biopsy view of a lipoma. You can see how it looks kind of fatty. That's what lipomas look like. But with histologic features of trying to differentiate between the three types of lipomas, or fatty tumors, lipoma, infiltrative lipoma, and liposarcoma, you want to have, I think it's O antigen or red O antigen staining. I'm not sure, but there's a specific stain that you look for as well to differentiate between those three types. But the other two ways of differentiating between those three types, beside the red O staining or whatever is based on physical exam findings, and then advanced imaging like CT and an MRI. And then, of course, like I said, the biopsy is what you really need to differentiate as well. So lipomas have a characteristic feature under histopath and clinically based on location, how difficult they are to remove. Infiltrative lipoma is a combination of physical exam, surgery findings, then biopsy, and liposarcoma, same thing. So anyway, it's a good review of fatty tumors, not in this paper, but for us talking about it. And yeah, we'll take it from there. We'll see you guys in the next one. Thank you so much. Bye-bye.